Welcome back to the show. As always, I am joined by my very good friends, Terry Fletcher, Scott Kraft, Stephanie Howard, Christine Hall. Unfortunately, Paul Spencer is off for the next couple of days. So I know we are all going to miss his candor and his punchlines that he loves to throw out periodically. But hey, welcome to each and every single one of you. We have a great program today. Terry and I were talking about how well rested Christine Hall looks after coming back from her Coding in the Caribbean cruise. That
We
I
had a
was,
great time, Sean, and we cannot wait for you to join us next year.
yes, I will. I will be there next year. I look forward to presenting and hanging out with everybody. Yeah, should be a lot of fun.
It was a lot
We'll
of fun. We had some sloths, some monkeys, some sea urchins. There were some adventures where we got into vehicles with people we didn't even know, but we had a great time. Of course, we had 18 CEUs, a lot of networking. We solved all the problems of the world, but we won't talk about that today.
And I bet it didn't snow at all. I bet it was really nice and warm.
There was not a sweatshirt in sight.
Yeah.
Well, I am getting ready to get bundled up because I have to head to the Northeast on a flight today about 4:30, and my understanding is it's still pretty chilly up there. So, with that said, we got a lot of topics to get through, a lot of great information that we're going to share with you. I want to start with the very first one, Terry. I want to go to you first because you, as always, send out great information, great links to help the rest of us kind of think through topics that we want to cover. And one of them was the release of the telehealth information that came out on Saturday of this past week. And it's a quick read. I'll post the link for everybody to be able to see that here in just a moment. But Terry, if you would go ahead and kind of give us um, your take on what's going on.
Well, to give credit where credit's due, I woke up at 5 o'clock in the morning and it came from Christine. So she's
Ah,
like, she's like, did anyone see this? I'll just start off the Monday, with a bang.
Pulled into port yesterday morning, and of course, you've been out of pocket for a few days, and the phone just started dinging and dinging and dinging. And I sent it to Terry and Stephanie, and I was like,
Whoa.
I'm gone 1 week.
Yeah. And I just woke up, I don't know why I woke up, and I would think it was 4:30 in the morning in California, and I looked at it and went, I'm going back to sleep. This is terrible. Well, so basically what it was in a nutshell, and actually I was a little amused, and I'm sure Christine, maybe Stephanie were too, is because remember during the PHE, we used to wait on Friday, almost like, at the window going open, open, waiting to see if they were going to extend it, and they extended it like a gazillion times, right? Well, Medicare likes to do this. They like to put things out on Saturdays, late Friday night, thinking nobody will notice. It'll just go under the radar, except us, geeks that like all this information. And basically, it came out and said, telehealth. They always say, "Guess what we do for you," and then they drop the hammer after the fact. So I went off and just said, you can use your phone. And it was funny because they said, like through your phone or computer. I'm like, a 12-year-old is writing this. And then it talked about through March 31st that you can get telehealth services at any location in the US as long as and if you're from your home. They don't always clarify the cross state line thing, so we won't talk about that. But they're basically was saying, if the patient's in their home. And then they said, however, as starting April 1st, 2025, you must be in an office or medical facility located in a rural area in the US for most telehealth services. If you aren't in a rural healthcare setting, you can still get certain Medicare telehealth services on or after April 1st. And I'll just give the three bullets. It said monthly end stage renal disease visits for home dialysis, services for diagnosis of treatment of symptoms of an acute stroke wherever you are, including mobile stroke unit, and then services for behavioral health and substance abuse disorder. So the stroke thing was new to me. I didn't see that in the last publication, so that's kind of new information. But then they just said, oh, some Medicare Advantage plans might, give you more, or if you're part of an ACO, which obviously they're trying to push that. And then that was it. That was the whole thing. They basically said, let's just do a drive-by, freak people out, and then, let them have a nice weekend. It was crazy to me to read that. So here's my take on it. I think it was preemptive. Right now, Congress is beating each other up on, who's better, who's worse, fraud, waste, and abuse, all that nonsense, which good, find all that stuff. But by the way, you also have a job to do. You guys are the ones that make the laws, that the legislative effort, and we can't do our jobs of telling people what it is. And Medicare, they can't administrate the information if you don't create the rules or extend the rules or make anything permanent. So, people are like, there was actually on the NSCHBC, there was a thread this morning where people are like, call your congressman. Well, to say what? I hate that phrase. And because what are you going to say? Extend telehealth forever? Extend it for everything? No. I mean, all of us are involved in audits all the time, and we see terrible telehealth records. Over the weekend, Stephanie and I were looking at a couple records and for endocrine, and doctors saying the abdomen was flat and not distended, and the talking about the sounds in the chest and all this. And I'm like, I don't think that was done virtually. I'm just making a guess. There was one that said no lymphadenopathy, and I'm like, so you actually touch the lymph nodes through the phone? I think Scott could comment on that. That probably, yes, he's a guru over there. So, and I'll throw it back to Christine and Scott, because there has to be some guardrails. There has to be a fix, because this is payment parity right now, and it's not the same as in-person brick and mortar. And I really think that this was just preemptive, saying that we don't know what's going to happen, so just plan for April 1st, going back to what it was. Christine, what do you think?
Terry, I looked at the, I'm a knee-jerk person, so of course when I saw that, I started looking at the congress.gov and looking at our 20 plus telehealth bills. And once I pushed the cobwebs aside, because nothing has happened, we're still at an introduction phase. I couldn't agree with you more, Terry. I think because there's so much that we are allocating all of our efforts in Congress towards right now, that we may not be able to get to these things by the March 31st date. So we're going to go back to the old way. And then maybe towards the end of the year, we might come back to telehealth. However, there's no promise of it. I really thought that Congress would take the time to at least recognize one of them, but it seems like we've got so many other things going on right now that it's been pushed to the side. Healthcare is something that I think really needs some love and attention. And, maybe they'll surprise us. There's
Well,
always
right
that
now,
last minute.
we finally got an HHS director confirmed, but he's working on chronic conditions and bad food, but we don't even have an administrator yet for Medicare. We have an acting administrator.
Yeah.
So Scott, I know you're kind of amused up there. What is your take on this?
I think there's a few ways to look at it. One of the things that struck out to me as we approached the end of last year, prior to this most recent extension, was the general lack of knowledge that telemedicine was not going to be presumably viable after January 1st. Paul, who's not here today, had mentioned on one of the podcasts that he had an appointment scheduled like January 6th, and he was trying to tell the provider, these changes are going to impact telehealth. And the provider was like, I don't know anything about that. So on the one hand, this could be taken as Medicare's way of sort of saying, like, look, today's February 21st or whatever day it is. You've got about 6 weeks to get ready for this. It may also be one of those things, what stuck out to me as somebody who tries to pay attention to things is the amount of misinformation that this announcement sort of brought into like the general media, right? Like Donald Trump is taking away your telehealth, which is really not true, right? Like this is legislation that was passed prior to him coming into office. I don't know if I've ever heard him mention telehealth. Certainly not in the 2.0.
I don't even think he knows what it is. Yeah.
He may not. And so this this may also be one of those things where by putting this announcement out there and sort of promoting this sort of confusion in the marketplace, people may choose to call their legislators. People may choose to say, well, okay, this is important to me, and I'm going to try to advocate for something to be done about it, whether it's, another extension, or whatever. And lastly, Terry, to bring it back to where you started, I agree with you 100%. This is something where the quality of the documentation, the increase in the number of visits, all these things, if this gets taken away, a lot of clinicians have nobody but themselves to blame because they've not put basic guardrails around how they're scheduling these visits, how these visits are being documented, how we can draw out the medical necessity for like a parity payment, right? And so I think there's a lot to take in there. And we've got a lot of stuff going on with our government right now. There's a looming funding shutdown. There's all kinds of balls in the air, right? And so I think for them to not get to telehealth by the end of March would not surprise me. It's interesting is the counter to that is our senior citizens, a group that every day I get closer to being part of. But our senior citizens
So do we.
tend to vote, and they tend to agitate for the results that they want. So it will be very curious if we get to April 1st and we don't have this extension, because I've said this before on this podcast. I think there are senior citizens for whom going to the doctor in person is a big part of their current social calendar, and they don't
It
have a
is. I
lot of
said
other
that
things
too.
going
Yeah,
on.
I
So
agree.
they may very well not agitate for this in the way that people think they will. So I'll just be curious to see what happens.
Well, Scott, also, I think the big thing that people seem to miss is that starting with the president, and this isn't negative, well, it's kind of negative, but starting with the highest, office in the land and then go filtering down to Congress and the House and all that, they get free healthcare. They
Yeah.
don't pay out of pocket. They get free healthcare. And so priority is if it's not personally affecting you, it seems
Yeah.
to be put to the wayside. And I think people forget that when you have to pay not just your copay and your deductible, but for your drugs and for anything that you want to have done, and you weigh, should I get that treatment versus can I afford it? That's where now you get into some really murky waters because the people making the decisions aren't in that group.
Well, and the third piece of that, which doesn't affect everybody, but does affect a not insignificant number of people, is access. Like being
Yeah.
able to find a provider, particularly certain specialty types, depending upon where you live. Can you get onto a telehealth visit versus going, to an in-person visit? For whatever we say about the availability of healthcare in this country and how it's, wherever it ranks in terms of systems, call a specialist for call a specialty that you're not currently engaged with as an active patient and try to get an appointment. And
It's
depending upon where
impossible.
you live, that's going to be a pretty substantive wait.
Well, and not only that, and again, I'm trying not to be political here, you guys, but Sean and I had conversation recently that, what did we just say? Call your congressman, right? So everything has to do with getting the win or trying to get somebody to do something in politics to make this work. But 42 billion and not one person connected to the internet. I mean, Christine and I have had conversations about this in rural areas and, not even rural areas. Christine, you said just there's areas that, just don't have internet. And so to me, access,
Absolutely.
just like you said, Scott, for people that can't connect to a video visit is a problem. And I've been yelling at this since 2020 and saying since the pandemic started, you got
Well,
to get people access.
I got a
I think
question,
what
though.
we would. Oh, go ahead,
Oh, I'm sorry,
Christine.
Scott. I just have a question. If Congress immediately saw the benefits of telehealth for mental health, substance abuse, telemental health services, how is it that that is so far away from medical necessity, medical problems that benefit? Like Scott was saying, I mean, some people are waiting months to go to an endocrinologist or rheumatologist, where telehealth opened that up. We can now see a doctor maybe across state, um, through telehealth for some of those specialties that are more data driven for care. But they're going to lose that relationship, lose that care that has happened. And we will see the cost of medicine go up trying to be reactive instead of taking 5 minutes to be proactive and keep this ball moving.
Well, and I think this is maybe my attempt to avoid politics and getting drawn in a little bit is I think, one of the things that Terry talked about at the outset that I agree with is the sensibility of telehealth, the documentation of it, And this is clearly an area that's rife for abuse, as we've seen, or rife for what we might charitably call inattentive documentation, if we want to be nice about it. And the challenge with our government sometimes is all of the solutions we come up with these days are like sticking a finger on something to kind of solve it, and not taking the global perspective of what should telehealth logically look like. I think, I would say telehealth probably doesn't need to be like a free for all where you can get it whenever you want, however you want, without regard to documentation. You get test results, you get billed for all these things, but it probably should be more than you have to be at some remote facility in order to receive a service, right? It should be about connecting you to harder to reach providers. It should be expediting your need for medically necessary services, and not just you have 2 chronic conditions. Rather than have you come in every 6 months, I'm going to put you on telehealth every 45 days, which is some of what we see. Like there's a gentle overutilization, at least in my view, that sits beneath the surface, and that's not insignificant when we're talking about trying to save money.
Well, and I'm seeing it now with transitional care management, where they forget that that includes either an in-person visit in 7 to 14 days. And yes, it could be audio and video, but now they're saying, well, we just call the patient within 24 hours and we charge a telehealth. I'm like, no. You have within 48 hours, you have to have a phone call that's included in that reimbursement. And, I still get doctors. I'm sure everyone on the panel gets doctors saying, well, I just called the patient for their test results. No,
Yeah, I was
I know.
gonna
See,
bring that up.
we're Stephanie and Christina were like rolling our eyes. Stop
Well,
it.
I was going to bring that up because I have different clients that are in the space of monitoring services. So not just TCM, but chronic care, RPM, all of that. And one of the things that they forget is they've got to have that initiating visit with that patient, especially if they're not established to their group. So what are they going to be doing at that point if their business model does not even have a building that the patient can come into? Some of the people that I've worked with, we had this conversation at the end of last year, just because, we had the big unknown. At that point, they had solutions because they did have providers who were able to go into like the local nursing homes, for example, to see those patients and do the face to face portion. But with these types of services, they're not across the board only telehealth or remote. You still have to have involvement with the patient. And one of the things that people are forgetting too, that have structured their entire businesses around telehealth services, is there's still the whole component of what you're going to do to use the information or treat the patient going forward. And a lot of that is missed as well. It's not just about, oh, I can have a doctor look at this, put it in order, we'll move forward. It's more so, okay, what are you going to do when you find an issue? It's not just being a resource, having things set up for the patient. When there's a problem found, what are you going to do about that?
Look, I think the biggest issue that we have, and we talk about what Congress is pushing out. The Congress people, much like our POTUS, have no clue what telehealth services really are. Very few of them may actually have an understanding for what they are, how valuable they are, especially to the elderly population, to underserved populations. I think the dynamics for what we have seen, because we've all had some interesting conversations about what is actually codified, what exists in the final rule, what is it that they're actually pushing out. I mean, there's been a lot of conflicting information. And what I think is even more interesting about this, and I think I heard somebody bring up the accountable care organizations, but I think my favorite line of this whole document is under the things to know, where it says Medicare Advantage plans and some providers in original Medicare may offer more telehealth benefits than the basic coverage in original Medicare. If you think Medicare Part C is going to offer anything more than what they have to cover, guess again. Remember, Medicare C is statutorily required to pay for what is on the covered services list and nothing beyond that. So be aware of this. The other thing that was brought up as part of the discussion was, why is it that behavioral health is the service that, is getting all of this attention and the flexibility to be. A lot of times it comes down to lobbyists. It comes down to the unelected officials, the bureaucrats who are looking to do things that are politically correct as opposed to what is actually best for the needs of the people. I agree, irrespective of, maybe telehealth shouldn't be mass rolled out for all just basic primary care services. But when you start getting into subspecialty services like endocrinology, neurosurgery, uh, interventional cardiology, some of these other, really in-depth subspecialties, I think we need to examine the immediate benefit for allowing these. I'm not discounting primary care services, but I agree. I have an 84-year-old mother, and the highlight of her week is calling me and saying, "Can you get me an Uber so I can go to my doctor's visit?" And I'm like, "Okay, first off, why are you going to the doctor?" "Well, they told me they wanted to have me come back this week." Okay, but why? I mean, I agree with you. I think people at my mother's age, it's on their social calendar. They look forward to this. They get all dressed up. She takes her fancy black bag. She puts on her fancy shoes and she's ready to roll to the doctor. Um, again, that's just part of,
But Sean, sometimes they do need that person.
No, I agree with you 100%.
Yeah.
Listen,
my grandmother would have been lost, to rest her soul, but she would have been lost without her visit.
I'm not going to survive to make it to that elderly stage. So my wife is going to be a very lonely old woman who's looking forward to going to these doctor visits. There will be no Cabana Boys. All right. So moving on, let's keep rolling here before I get myself in more trouble, because I know Terry's going to wind up sending Jill a text.
No,
Scott.
Scott has
the one last thing I wanted to say about it, and I think this relates to what you're saying. Like I would push back a little bit on primary care only because like I think there's a smart way to do telehealth, and we don't really have that conversation. We just kind of think of it as all or nothing. Like I'm fortunate to be a relatively healthy person. Stuff kind of goes off the rails once in a while. But how often is it when you wake up and you don't feel good and you kind of know you need like some sort of prescription antihistamine or some sort of cough medicine? And I call my doctor and it's like Monday morning and they're like, "Well, I can get you in like Thursday morning." And I'm like, "Well, this is ridiculous, right? Like this is exactly why like urgent care is a thing. Like this is, it ends up becoming like a non-urgent urgent care visit." And so when you think about, and I've told this to clients I've worked with before in primary care, it's like if you had, a telehealth sort of fast track to get people what they needed, that would probably be like smart for you. Now, the one thing I was curious about that I've noticed this as an auditor, sort of beyond primary care. I would be curious to know, it's probably an unobtainable statistic, but like prior to COVID and post-COVID, what the percentages of telehealth and inpatient visits were by provider. When I say inpatient, I mean in person, like telehealth versus in person, because I'll do reviews and I just kind of go provider to provider, and you'll do a provider review and it's just telehealth all day.
So I will tell you, Scott,
that too.
So Scott, I will tell you, there was actually a number out there prior to COVID-19 happening. The number that I saw was less than 10% of all patient visits consisted of a telehealth visit. When the public health emergency hit, 85 to 90% of all visits were telehealth visits, right? Obviously, we had everything pretty much shut down. The last number that I saw was about 50% of the services are still being performed as telehealth. And again, I wasn't trying to dissuade telehealth in primary care. I think there's a smart way to use it. I agree with you 100%. I think what Terry and I have talked about on #Terry Tuesdays is the way that some of these providers have tried to utilize telehealth services by saying, "Hey, I'm in the car for the next hour and, I can earn some extra money. Let me do some telehealth services. See whoever has a follow-up visit that couldn't get in this week, and I could discuss their MRI result or their labs, or I could talk about their statin with the pain that they're getting in their tushy from it." I mean, those are the kind of things that I think lead to an abusive situation. And I think those are the things where we're going to continue to see the UPICs and the RACs and the MACs, the TPEs focusing their attention on telehealth services, because I think a couple of things. One, I don't think a lot of providers have the proper disclaimer to, support these services. One. Two, I think people are still screwed up about what place of service to use. And three, I have yet to find great overall documentation for supporting a telehealth service. I mean, there's a couple of providers that I think have done a good job, but I think if you're looking at it as a collective whole, and you guys tell me, because you're into records way more often than I am, I just haven't found the majority of providers documenting these services to the level that you would expect.
I think it
give
depends.
A little clarity to that. Sorry, Scott. So
yeah, please.
A little bit of clarity to that is for telehealth is not new. Terry will tell you telehealth has been around for decades. It's been very successful. We've used telehealth in schools. We've used telehealth with private waivers programs through the Medicaid programs. Telehealth has been a very robust part of healthcare for a long time. What we didn't see telehealth was for your regular visits, your regular medical visits, and a lot of the specialty visits. And my face is melting.
You just seem a little cloudy.
God, in a good way?
No. Your connections just seems a little off.
Oh, that's
I can hear you.
We can still hear you well.
Yeah, we can hear you.
Well, that's okay. I have a big mouth. So here's the thing. Over the past couple of years, or since the awakening of COVID, a lot of these waiver programs realized that they were not utilizing healthcare benefits before utilizing waiver money or different budget money. So states like Ohio, like California, have revamped how those claims are processed. And now it is a bigger deal because more people are now having to access Medicare, Medicaid, commercial insurances for these visits that may have been covered previously by waiver programs or some sort of a state program that was funding that. So that's why we are seeing a lot of it and why it's such a big deal now that we're talking about it. It's not that telehealth is new. It is that telehealth restructured over the time of COVID, and now insurances are the payers, or the waivers are the payers of last resort, and the insurances are having to come in, and we're having to develop new ways of doing it. In a waiver program, it might have been perfectly okay to call a patient and do medication management paid by a waiver program. That is not okay to do through the healthcare benefits. There's no benefit for that in there. And there's a lot of confusion about that the way that we use telehealth today. And I think that's one of the things that's creating more conflict here. Yeah.
All right. So we've spent a lot of time talking about this. I want to move on because we could talk about this for hours. Let's move on to another topic. I think everybody has made great points and salient points, and I think there's a lot that needs to be thought through at CMS and in Congress to figure out how to make these services permanently available, especially to our seniors, irrespective of whether they're in urban or rural or underserved areas. I think it should be something that is readily available to all patients that need it, especially to our senior population. All right. I want to move into something that I think is really an interesting topic, because I think it will lead into the discussion of the last few. E&M macro statements of time that are the same for every patient. Okay, so while many prosecutors have gotten away from making the impossible day or medically unbelievable day argument in federal court because of the number of acquittals of providers, because they didn't take into consideration the use of ancillary providers and things of that nature to help, that are used that spike a provider's numbers, right? So I think a lot of prosecutors, got blindsided by being told you can make this argument by somebody at the UPIC or somebody, in OIG or whatever, and it went sideways when it went to trial. I mean, I've seen myself personally, just in the last couple of years, probably 10 acquittals on a charge of the medically impossible or improbable day. But there's only so many hours in a day. And there's only so many hours in a day where providers are actually seeing patients. So if you are using a time statement for every single patient that you spent 40 minutes face to face with the patient and you saw 50 patients that day, we have a problem, Houston. So I want to unpack this if we can. So Stephanie, let me start with you because I know all of y'all have seen this issue, but I want to start with you on some that you've been seeing, and then Scott and Christine and Terry, I want to kind of go to each of you and get your takes on this, please.
Yeah, so this definitely can come about in different ways as far as what we see in documentation. And I think one of the funniest scenarios we had, Sean, you and I dealt with this years ago when a group I shouldn't laugh, but I'm going to. A group was looking to get rid of a physician who was pretty problematic in pretty much all areas of the practice. And when reviewing documentation, he continued to put these time statements in there, and he was doing start and stop times. So he probably thought, oh, this is great. I'm listening to these rules, or at the very least, the start time. So I started to have questions about it because he was basically adding additional services in based on this canned statement that was the same for everybody. And I noticed that the times were either the same. It was like, let's say 9:18 in the morning. So that was a little weird. Why is everything 9:18 or 8:18? And then if there was variation, it was just by a minute or two because some providers, I actually had this question last week, think that if they add a minute, take one or two away, it's going to look a little better, right, on an audit. So what ended up happening, I had a lot of concerns because of these add-on codes he was putting in there. And I went to the practice manager and all I had to do was ask about that start time. And that was the time of day that he was driving into the practice every single day. And his canned statement was referring to reviewing documentation, basically prepping for that visit. But based on where he lived, where the practice was, and when he got there, that was always when he was driving in. So there's ways to look behind the scenes if we have those types of concerns. And for me, one of the things that I like to talk through, for example, if I work with rheumatology or I had another specialty group I was working with recently, and one of the questions I'll ask them if I see a lot of the time relatively the same is, for example, how long do you schedule your new patient visits for? If they're scheduled across the board, every new patient at 60 minutes, and you're dealing with rheumatology, neurology, whoever it is, where they have a large intake of information, a lot of past history, they tend to be what we would call a provider of last resort, meaning that they've already seen many others that have done a lot of workup, testing, a lot of unknowns. They still haven't figured it out. So that to me makes sense. But if there's going to be a time statement that is canned, we still have to see that individualized work of the encounter somewhere. And I don't know, we may have some differing opinions on the panel here, but for me, if I see the macro statement showing generic activities, for example, I'm not as concerned about that if I can see the detail and what was taking place in typically the assessment and plan. So there's a lot of different ways that this can come up in documentation.
Go ahead, Scott. I know you said you had something
Ooh,
percolating on this one.
yeah. So I'm going to say a couple things about these macro time statements. I want to start by saying that one of the things that confounds me a little bit in my work is I find that the people who I have the most difficulty with when it comes to articulating how time is documented, its medical appropriateness, usually are like practice administrators, like the people I'm working with who are my contacts at the practice, who don't have any guardrails around how providers are using time, other than maybe to say that the provider has to update the time documented for each visit, so they can't just sort of carry that piece of it forward. But I think, one of the things I've said about time, going back to our previous time rules, is that when left unchecked, the use of time or the overuse of time tends to degrade the quality of the documentation itself. So you just get in the habit of saying, like, I spent 30 minutes or 35 minutes or however many minutes, and you look at the note and you're kind of saying, well, okay, well, what really happened here? And I think these cover or catch-all statements don't really help when I may be looking at a note that has like 3 updated words. And I think the thing to be cognizant about when documenting time is the payer pays for what's medically necessary for the patient on the day of the visit. And my concern is that providers are starting to use time in effect as a license for longer visits. So suddenly you have all of these 30 to 40-minute visits when in most other providers are probably handling these things in like 20 minutes. We have providers who are saying, I spent time preparing for the visit by reviewing all the old documentation, but it's all your own documentation from when you saw the patient, last month. And, I would encourage people who are in practice leadership, people who are in compliance at the practice level, to be thoughtful about the parameters you're putting around providers when they're using time, because I will go in and do a review and I will not support a time statement for a handful of reasons. Sometimes it just practically makes no sense. I did an urgent care audit where the patients were coming in with like strep throat or sore throats that were not strep throat. And every visit was, I took 30 minutes, I took 30 minutes, I took 30 minutes. And so it's almost the opposite of what Stephanie's saying, where it's not so much about the scheduling and accounting for the time versus just you are documenting these time statements and you're asking the payer to in effect overpay based on what's being covered by other providers, right? And that's before we get into, some of these statements include things that were not done, right? So these canned statements will say, I spent 30 minutes with the patient on this day. It includes reviewing, labs and tests. And then you look and there are no labs and tests, right? Reviewing imaging. Well, there is no imaging. And my favorite, where the provider says, I spent 30 or more minutes with the patient on this day doing one or more of the following things, and then goes on to list like every single thing they could possibly do for any patient at any time. And, look, I think when you sign your name to a medical note, you're doing so under penalty of perjury, all the things that we talk about. And some of these time statements are just, they're so diametrically out of sync with the nature of the services that are provided. And what frustrates me as a sort of third party auditor is I think internally a lot of providers are being licensed, for lack of a better word, to do it this way by people in house. And the one thing I appreciate working with a lot of bigger health systems is a lot of these really big health systems, they prefer to like create policy with like a sledgehammer, right? Like, this is the policy, and if there's no nuance to it, I can just put it out into the universe and I can endorse it across the board. But that's really not how the creation of medical documentation, it's not how the auditing of medical services works. And so when the provider gets this message that just says, well, when I say it's 30 minutes, it's a level 4, then you have, all of these 30-minute visits. And even if the provider is spending the 30 minutes, as I always tell the providers I do education with, like, you've sworn that you spent 30 minutes. I don't feel like I can challenge that. However, there are medical necessity considerations that sit behind the time. I do think it's problematic from a resource utilization level. It's as though I decide as a provider that I will allocate every patient 30 minutes and I will bill for them on that basis. And maybe I'm only seeing, I don't know, 14 patients a day or something, but I'm making the same money as the guy down the street who sees 35 patients a day because I'm just pushing them through. And you can't sort of decide you want to be like a concierge style provider through this sort of backdoor mechanism of just saying everything took a certain amount of time. And so, it bothers me. It bothers me a lot because I think, like I said, I had always been concerned that once a provider really leans into documenting time, it often comes at the expense of a true accounting of what happened with the patient on that service day. The documentation sort of suffers in the margins in terms of what gets carried forward. But I would encourage, again, like the listeners who are working in compliance, who are working in auditing or billing functions at the practices, to be mindful about what you're telling your providers about the use of time. Because I feel like when I challenge time as a third party auditor, like I may have the internal compliance people with me in a lot of work that I do. They kind of jump to the other side of the fence and say, well, she did say it was 40 minutes. And it's like, okay, the patient has like a modest rash that hasn't expanded in any form or fashion, and they're getting an antibiotic. Like, I sort of want the provider, like, I want to go in and say, okay, let's reenact this visit, right? Like a Civil War reenactor, but for medical practice, long time visits, and say, I'm going to set the clock for 40 minutes. Let's do this again so I can see how you're spending this time. Because I do, I said in the internal chat that I had a little bit of a rant about this, and I do, because I think it is at its heart becoming abusive in many ways.
Well, also, I'm getting emails. I got two. I think I forwarded to one of you this past week from payers. A really big payer said, so I have a problem. I see what the CPT book says. AMA is saying as long as the time's there, we can't really question it. And it's clear that it wasn't, there's no way that could have taken that kind of time. And then we see those macros or smart phrases that says every single time, 30 minutes or 25 minutes spent and, getting ready for the patient and doing the charting, and it's very generic, right? It's not specific to that patient, which 2021 new rule says it's to be specific to the patient. They said paper, what is it? Patients over paperwork. That's why we don't count bullets anymore and all that kind of stuff with the history and exam. But we're finding that a lot of the old bad habits are reverting back, and they have. And so I said to the payers, I said, okay, so here's what I would do. and to Scott's point, I said, I would look at the schedule, say, okay, well, send me your schedule for the day. I want to see how many patients you saw in your block time to see patients. And it was funny because the payer came back to me. I didn't think she would. And she goes, so we did that. She said, they agreed to our refund request. She goes, they didn't even want to send us the schedule. And I didn't want to be amused, but I said, really? She said, they panicked.
Yeah.
And said, well, how about if we just send you the refund request and we won't do that anymore. We'll take out that statement and just do them. And I went, wow. And she goes, yeah, now we want to expand our audit for the last couple years.
That's what I was going to say, Terry.
They're like, yeah, you know what? Because it turned out, so the second payer that asked me this, one of the biggest payers in the country, they said, well, we insisted on it, even though they didn't want to do it. And both payers said they were totally different ends of the spectrum.
Yeah.
Said they didn't want to send it, but one insisted and one just took the refund back, but said they were going to re-audit them in 6 months.
That kind of blind issuance of a refund and saying, oh, we won't do it again, especially depending on what the dollar amount was.
It's like a big light bulb. It's like, oh,
well,
shoot.
yes, but it's an excellent opportunity for, if it was CMS, for them to be able to say, let's send this over to the Unified Program Integrity Contractor. Right. Let's conduct an investigation. Let them audit the records. Let them go through it. You're right, because remember, the look back period on this stuff is 6 years.
Yeah, well, one was a Medicare Advantage plan and one was a commercial plan. And the one that actually asked for that wanted the schedule no matter what. And they also threatened to call patients. I'm like, oh, you guys, because I said, there's no other way to find out than actually look at the schedule. Is it a believable day? Like Sean said, and so they asked for it. And it turned out they were scheduling patients every 7 minutes. And I know. And they were putting in 25 to 40 minutes so they could get the level. Well, it's not level 4 anymore. You have to hit 30 minutes, but they will putting in level 4s and 5s. And there was no way, unless they were seeing patients 36 hours a day.
So we're on this time thing, right? And there's a time expectancy file. And this time expectancy file kind of drives me nuts because it's just numbers, right? It's data. There's no great explanations behind it, but I think I know where my friend Christine Hall is going to go with this. So I'm going to let you run with this for a few moments and talk us through it.
I appreciate that. So, I think my very first word was why. I want to know why. I want to know how come. I want to know the nuts and bolts of things. So I do look at the Medicare's time expectancy file that is updated every year with the final rule. And in that time expectancy file, like you said, where do the numbers come from? I don't really know. I'm not a doctor.
Right.
But the file gives us a great idea of what's expected pre-evaluation time. So for
Yes.
like a 99213, you got 5 minutes of pre-evaluation time that's expected in that visit. So maybe that is the medical assistant getting the history. Maybe it's you reviewing the history. Maybe it's you reviewing the past labs. Maybe it's you reviewing the past data, whatever that is, right? They figure about 20 minutes of actual evaluation time. So to go to what Terry and Scott and I know Stephanie's going to say this too, is a 20-minute evaluation. And it could be any of that data. It could be that you're looking at the history of the patient, you're continuing that conversation, or you're doing a more thorough examination, or you're looking at drug interactions, or you're looking at values from physiological data that's come in. But we kind of get an idea, and then it even tells us that there's 5 minutes of post-op. So here's the diagnosis, or here's what we're going to do, and explaining that to the patient could take anywhere from 20 minutes is what the CPT guidance is, but the time could extend to 30 minutes of a 99213 visit. And that, I look at that as what is average. It could be a little bit more, it could be a little bit less.
I wanted to comment on something on that, Christine, because I think
sure,
people
of
miss
course.
this in the CPT book. On
Yeah.
page 13, 2025, and you're on the right-hand side under guidelines for selecting time of service based on time. It is the fourth paragraph down. It says, for coding purposes, time for these services is the total time on the date of the encounter, both face-to-face with the patient, family caregiver, and non-face-to-face time personally spent. Personally spent by the physician and or other qualified healthcare professional on the day of the encounter. That includes time and activities that require the physician and other qualified healthcare professional, and does not include time of activities normally performed by clinical staff.
Terry,
I mean, they're clear.
Terry, thank you. Thank you. Okay.
Because people don't get that.
So let me just say this, because I mean, this is one that we could go on and on and on about this. I absolutely hate providers billing based on time, unless it is really the counseling and or coordination of care. Right. It's a consultative visit. Other than that, focus on the medical decision-making, focus on the medical necessity of the services, build your plan of care up, add relevant, critical information about what you observed, what you believe the best course of action is. Put differential diagnoses in there, because at least it shows your thought pattern, your process for how you're trying to get there. I still look, as much as I hated the bullets, right? The counting of beans, I still love an extensive history of present illness. I still love an extensive chief complaint, right? I love a clear, concise statement for the reason of the encounter, a symptom, a sign, a condition, a physician recommended return, whatever it is. And I love it to be in the patient's own words. Sean Weiss said that he's here in the office today for evaluation of blank because of blah, 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 blah. That's what I want to see. And I want to see a plan of care that says Sean Weiss to restart colchicine because there is pericarditis, 2 pills, 20 milligrams BID. Okay. Now you're showing prescription drug management. You're giving the reasons why you're prescribing these medications. You're showing your clinical judgment. This whole thing with providers saying, well, my nurse was looking at the notes and she told me that she spent 10 minutes in the chart pulling all this stuff together. Well, that's great. Congratulations. It's non-countable. That is non-counted time. This is the thing that gets providers in trouble in audits again and again and again when it comes to the commercial payers, the SIUs, the UPICs, the MACs, the TPE auditors, especially Scott, you and I have seen them absolutely crucify providers for time statements that can't be substantiated. So be careful with this. Let me give you all the last word on this
Well,
topic. I think it was a great topic.
I
Thank
was
you.
going to say a couple of things about it. Like, I think it's also one thing I will also note about time is the time rules do not allow you to transfer work to the provider that is customarily done by ancillary staff. And so you can't start like weighing people if that's not what you historically do. The last thing I want to say about time is my feeling about time, sort of related to what Sean said, is it should be reserved for instances where there is a visible, and when I say visible as an auditor, I mean in the documentation, a visible deviation from the standard of the medical decision making for that service, right? So in other words, if you're just managing two chronic conditions and you're refilling medications, that's typically a level 4. Like, I don't need you to necessarily tell me it's 30 minutes. I think some providers just get in that habit of putting that in there. But look, if the patient is starting a new medication and the patient has a lot of questions about the timing of when to take it and what to take it with and blah, 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 like, I should be able to see that in the documentation. I should be able to correlate that in a way that says, well, okay, I understand why this otherwise 99214 visit has elevated to a 40-minute visit. It shouldn't be, I spent 40 minutes with the patient today reviewing the records and checking the labs and doing all this other stuff. I should be able to appreciate from the documentation, going back to the patient's not paperwork and we're not counting bullets and all that. Just give me like your plain English sense of how the patient's doing today and what happened in that visit. And if you do that, and then you say it took 40 minutes, I should say, well, that makes perfect sense to me, rather than this gymnastics around what I reviewed and didn't review and all that.
Terry, you're muted. Oh,
I am muted.
I was
Oh my
so
gosh, you
looking-
could
I
have
was
made
so
such a
looking-
joke on that one.
I was so looking forward
I
to
know
saying
you
something because
were.
you
I
talked
know
about
you
how much
were.
people enjoy me being muted.
Oh man. So one of the things that I think also people miss are those canned statements. It's amazing how every single patient hits 30 minutes for the level 4. I'm just like, wow, or 40 minutes for the level 5. And you just look at that and you shake your head and roll your eyes thinking, I don't know if you've seen that commercial with the Staples button. And are you talking to the patient and you're in there doing it and you're like, wait, nope. And you press the button, go, I got to go because I've hit my 25, 40 minute, 30 minutes. And it's just absurd to see this on every patient. So when you audit, we usually auditing if we're doing it formally for a practice, 10 to 20 records a provider. And all of a sudden we see it the first time, we're like, okay. Then we see it again. Then all of a sudden we see a pattern. It's the same macro smart statement in every single, patient. You're just like, oh my gosh. And then I want to see the schedule.
Yeah.
Because most schedules, I don't care if you're in Epic, I don't care what system you're in, is usually patients are scheduled every 15 minutes. And so when you say that, and I see some providers say, well, that also includes non-face-to-face. Yes, it does. But again, for what you do. And are you saying that you've got a little time card on you and what you personally have done with that patient after they leave the office? I don't see that. I don't see proof of that. And so that's where it becomes a problem.
Yep. So the last topic that I want to hit, and I think the two prior conversations lead us right to this. And Stephanie, I want to start with you on this one because you and I have a lot of process conversations we have over the last decade. So I want to talk about workflow setups versus compliance, right? And I think, Terry, this was such a great topic that you brought to the roundtable. And I definitely want to come to you after Stephanie, and then Christine and Scott. I want to give you the last words on this one, but I want to start with you, Stephanie, because to me, because I work with you more than I work with anybody, basically, and it's crazy. I'm a huge fan for your process. But I also know that when you're looking at process, you're looking at what makes sense from a compliance standpoint. But where do the lines get blurred?
Yeah, so there's a lot to unpack there, but one of the things that really depends on at what point of the process or the program, I guess I could say, that's set up inside of a practice is at. So, what I mean by that is if we're having conversations before services are being offered, that's going to look a lot different than if it's already being done and you essentially have a train wreck because people weren't looking at compliance to begin with. And this is something, Terry and I actually had a meeting with someone last week as well. And I've had this conversation with a lot of clients, especially last year, about the weight loss drug subject. And the whole issue there is that they don't realize the way that you would have to dig in from the clinical side, for example, and do research related to the drugs that they want to offer patients, the FDA approval, the FDA label, even pharmacy. How is the patient going to receive this from the pharmacy? Then we have to ask questions about, okay, is this going to be in person? Are you going to do telehealth, which has its own struggles? And in staffing. So it's one of those things where if there's a compliance issue, you always have to backtrack into that workflow because you're going to identify things that, even if it's outside of what I do, maybe it's a hiring issue. I don't deal with HR, but I know how that feeds into the compliance side of things. So you have to look at everything from the beginning to the end, see who all is involved in that and what needs to change to make it compliant. And I find, and I'm sure most of us find, that a lot of times, especially when I'm in a large hospital system, nobody asks compliance. They just look at clinical, the doctor wants to do something, or the practice has a new line, or they, the famous scenario of they went to a conference and they want to do this and they heard it works or their friend does it. Nobody asks compliance until we see it after the fact. So it's really important to have conversations. When I work with clients for the first time, I'll even say, what services are you doing that are new? Is there anything new in the industry that you're wanting to try? All of those types of conversations are what really need to take place to try and get ahead of this. But most of us see this after, when we're dealing with the mess,
Yep.
unfortunately.
And Terry, so let me ask you this question, because again, process is so critical, right?
Yeah.
And workflow, setting up and establishing your workflow is so critical, especially you as an auditor for commercial and governmental plans, right?
Mhm.
And knowing that your work could be challenged by the appellant, what steps are you taking and what can you guide the listeners who are responsible for audits in their organization? What guidance can you give them on establishing the proper setups and versus what is actually compliant?
Well, it's hard to, that's such a huge question. I mean, I could go on for a long time just, unpacking that. But the biggest thing, and I think Stephanie actually hit on it, and I'm sure Christine could comment on this as well, is that the departments need to talk to each other. We're finding that, one department takes care of preventative and another department takes care of sick appointments. And all of a sudden, everyone's doing something on the same day. And you're looking at the workflow and how this goes. And it almost, in our mind, looks like the patient's just walking across the hall to all these different areas where you don't have the medical necessity there, or the time element for everything to be done on the same day. And once you start becoming the Costco of healthcare, basically one-stop shopping, it becomes an issue. One thing that Scott said to me a couple of years ago, and I've saved this email, where doctors are saying, well, this is how I'm, all my patients are this sick. And it's funny how every doctor's patient's sicker than everybody else's. He's like, well, if you were Little House on the Prairie, Dr. Baker. And I always use that because coming back to, 21st century medicine, you got to be cognitive of what's going on now. And I think Stephanie hit it on the head. The departments don't talk to each other. It's amazing to me. And when you're in a smaller practice, I've noticed smaller practices, they don't just try harder, but I think there's less ability to get in trouble because everyone's just doing, kind of singular things. But once you get into these big hospital systems, into these really big practices, especially multi-specialty, and I'll let Christine take the last one on this. It just becomes like everyone's doing their own thing and not realizing that you've got to stay in compliant together. Otherwise, it's a mess.
You know, and I say this every single roundtable. You cannot afford to not have a compliance consultant coming in and looking at your organization from that bird's eye view. This is a great example how people are siloed in different departments. And until you get someone in there to look at everything and provide you with some real solutions and maybe some assistance with how to migrate some of those departments together, at least get them once a quarter at the table together to understand what's going on, you know, we're just going to continue the madness. So that's my take on it. Is you've got to find at least one champion that can help collaborate all of these efforts together.
All right, Scott, any last words?
No, I think they covered that last piece fairly well. And I think the specifics around Doc Baker was that I had a pediatric provider tell me that prior to the invention of antibiotics, otitis media could be fatal, and therefore it should be a 4-5.
All right.
Yeah.
On that note, I'm going to say thank you to each and every single one of you for tuning in, logging on, and hanging out with us for just a little while every other Monday as we get an opportunity to discuss the biggest and most critical topics in healthcare auditing, coding, billing, and compliance. Terry and I are going to be back tomorrow with a brand new hashtag Terry Tuesday. I can't wait to hear what she throws at me during our talk tomorrow. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.